Decoding AORTA, AORTIC
Window that comes to
Masterclass.
a very bright picture. So you window it, that means you adjust the contrast, as you can see here, so that the contrast or the contrast in the vessel is more of a grayscale. So this helps you in two ways. Number one, it's reduces glare to your eyes, and number two, you can also differentiate the contrast and the calcium in the arterial wall or the vessel wall much better. So you can see here in this picture, in the iliacs particularly, there is dense calcium. You would not see this if it was an unwindowed image. So you can differentiate calcium and contrast very well, and also the thrombus is also much better defined. The next thing you ought to do is take a measurement, because you want to confirm whether you are doing the procedure for the right indication. A fallacy in this step is, if you notice, most aneurysms as they grow, they tend to bend or deviate. The reason being, they have to now accommodate in that previous restricted space. So if you take a measurement, for example, of this aorta aneurysm through the transverse plane, you will get an unusually long oblong measurement. So a simple rule of thumb is to measure aneurysm diameter is the AP diameter, because almost never does an aneurysm bend or deviate in the anteroposterior plane because of the restriction of the posterior muscles in the spine. So if you want to know a reasonable size of the aneurysm, measure in the AP diameter. Next, a classic dictum or maxim in radiology is never be satisfied with just one plane or one view. Always look for multiple views of the images, because if you stick to one plane, you may miss a lot of findings, and that could end up being very disastrous. So what we do is what we see is what is known as a multiplanar reconstructions. So you can see the axial images in coronal views, sagittal view, etc. So this sometimes already preloaded in the DICOM data or in the packs. But if not, you can also use the axial images you have and software to reformat into these multiplanar views. So this is something that I've done in a software called Radiant DICOM. So you can see that the axial and the coronal and the sagittal are seen simultaneously. So you can scroll through one and simultaneously see what you're seeing in the other views as well. The coronal view is also very useful in that it gives a surgeon's view. That is, when you're doing an laparotomy, what you expect to see will be something similar to what you see in the coronal view. And the sagittal view is useful for the retropetal approach or the thoracoabdominal approach, that you have suprarenal or typhothoracoabdominal aneurysms. So now to a step-by-step schematic approach on what all you want to see in your CT angiogram. First and foremost, of course, we want to see whether we have a safe clamping zone. So the neck of the aneurysm and the renals. Is there adequate infrarenal neck to clamp? If not, where can you clamp? Can you put a clamp in between the renals? That is called an interrenal clamp, or you have to go suprarenally. What is the direction of the neck or the angulation that is there in the neck? So that would help you decide in which direction you want to dissect the aorta approximately, and also how your clamp would sit. It may not sit transversely, you may have to put it perpendicular at times. Is there thrombus or calcium in the neck? If there's thrombus, it indicates that your neck may be weak and may not take stitches properly. Calcium means, of course, you may have trouble putting clamp safely or even taking stitches. Again, you need to look at the renals in detail. If your clamp is very close to the renals, is there renal ostium disease? Because you could cause plaque shift and damage to the renal artery flow. And again, accessory renal arteries, sometimes they are seen. If they are there below the main renal artery, you need to particularly locate them, because when you put your clamp, you may be jeopardizing these arteries. You need to decide whether you want to salvage them or sacrifice them. So an example of this I can show you. So this is the axial and a coronal view. Going slow at the aortic neck, you can see that it's a pretty bendy, deviated aortic neck, almost 90 degrees. Again, in the coronal view, you can see that. So if you look here, so first thing you know that if you have to dissect this aorta, it's not going to be right in the midline. You have to deviate towards the left side. And when you get the clamp space, your clamp is going to be sitting almost perpendicular rather than transverse. So all these things should come in your mind when you look at the CT. One more thing that you can pick up is an accessory renal artery on the left side. So this accessory renal artery was about 3 millimeters. It is just above the aneurysm sac, which means that if you have to clamp above that renal artery, that accessory renal artery. But you can salvage it by doing the anastomosis below. Generally, we try to salvage accessory renal arteries if they are more than 3 millimeters, but if they are less than 3 or 2, it is probably okay to sacrifice these. Next, we scan through the other branches, the lumbar arteries, the inferior mesenteric, and the other mesenteric vessels, internal iliacs. So, eyeball through the axials to look for any patent lumbars that you would have to be ready to stitch as soon as you open the sac. And then you look for the mesenteric vessels. So, this you need to be very careful in. Sometimes you may have disease in the superior mesenteric celiac or the other arteries, and the inferior mesenteric may be a very prominent or important artery supplying the mesenteric territory. So always look at all the patencies. See if the IMA is significantly hypertrophied and there's a large meandering artery, which means that this IMA is probably the predominant supply to the gut. So if you look at this particular example, the patient had bilateral occluded internal iliac arteries, and there's a large collateral coming from a prominent IMA going to the pelvis. So if you do not salvage this IMA, you would end up in significant pelvic ischemia. And then finally you come to the aortic bifurcation. You assess whether it's suitable to do a distal anastomosis as a tube graft. Is there significant calcifications like you see here, which means that you may have trouble, you may have to decalcify those areas before you can take the stitches. Or is it too splayed? So if it is too splayed, even if there is no, if the aneurysm ends at the bifurcation, it's very difficult to do a distal anastomosis to a very splayed bifurcation. You may choose to do a bifurcated graft. Again, if the iliacs are aneurysmal, it's obvious that you need to do bifurcated graft repair and extend it to beyond the iliacs. You can also do a rough estimation on which graft you want to select in the CT. You can measure the diameter of the aortic neck and of all the aortic bifurcation, and this can help you judge approximately an error of about 2 millimeters, perfectly fine. You can select which graft you want to select to do the anastomosis. Again, if the bifurcation is bad or you have to treat an iliac aneurysm, you obviously choose a bifurcated graft. Be wary to look for high-risk features. So something like this, you can see a bleb in the anterior aortic wall with a break in the calcium, or if you obviously see fat stranding, all these means that aorta is impending rupture or it's already started leaking and you need to take this patient in fast. Unusual morphology like saccular aneurysms or those that look very lobulated could mean mycotic and mantle sign, which means a thickening of the peri-aortic soft tissue indicates this could be an inflammatory aneurysm. You need to rethink your strategy whether open surgery or endovascular. Variant anatomies that we again have to keep a keen eye to look for is we not uncommonly see venous anomalies. One common one is called the retroaortic renal vein. So if this is there, if you can find this in the CT images, it means that you don't have to specifically look for it when you're doing the anterior dissection of the aorta. And also when you place the cross clamp, you should be very careful not to impinge this vein, because if it bleeds, it's very difficult to view and you may end up having a terrible bleeding. Another possible anomaly is the renal artery anomalies. You can have pelvic kidneys, ectopic kidneys, and these arteries may be coming from the aortic bifurcation or the iliacs, and you would have to give renal protection and reimplantation of these arteries. Finally, you can also do some recon images to have a wholesome view of the situation. So one particular recon is known as maximum intensity projection, or MIP. So here what is happening is you're stacking multiple images together so that you get the whole aorta in one single plane. The other one is obviously the virtual reconstruction technique, or VRT, 3D reconstruction. So the advantage of this is it helps you quickly revise your plan just before you go in for surgery, or if you want to discuss your plan with your teammates or with anesthetists, these images are helpful, of course, with the patient as well. One word about the contrast imaging. You can also use, or MR imaging, you can also use that as your preoperative imaging tool, particularly if your patient has renal insufficiency and you're concerned of contrast nephropathy. There's the benefit of no radiation being involved as well. The cons being that vessel patencies are not as well precisely seen as in CT. You may tend to overestimate stenosis, and again calcium is not seen in MR, which is something we would always like to know when we go for open surgery. It is nice to get familiar with some DICOM viewers. so that we can go through these images at our leisure by ourselves. So one very user-friendly interface is the Radiant Dicom viewer. This is available for download freely. But unfortunately, it's only for the Windows system. There's another one called the 3Dicom, which is an online software. You can directly view your images by uploading onto the website. And then there's the AORTIC, which is useful for Mac users. So I'll just quickly run through a couple of CTs in the Radium Dicom. So this is, for example, a patient who is 56-year-old who came with an intrarenal aortic aneurysm and a CT angiogram taken. So like I said before, this is the default window that you get. It is quite bright. So what you need to do is go to the contrast button and just window it like this, so that you get a more pleasant view of the scan, and then you start running through the images. So you quickly screen thoracic aorta and make sure you're not missing any aneurysms in the thoracic aorta. Then as you come to the abdomen, first thing first, you're going to eyeball the aneurysm itself, of course. So you see that there's a nice infrarenal neck and the aneurysm starts. So like I said before, you can take the measuring tool that's up there, and you can do an AP diameter measurement. So this came as 3.5, 3.4, 3.5, sorry, 5.3, 5.4, but since he is a young person and a relatively small big person, we considered him for open surgery. And again, coming back to the neck, so you can see that it's a pretty decent neck. Both the renals are nicely patent. There is no accessory renal artery. And then your celiac mesenteric vessels are patent. Coming back down, there is one lumbar you can see here. So that is something that you may have to deal with when you open the sac. It's close to the neck. But otherwise, there is no much lumbars. The inferior mesenteric artery is about there. So you can see that it's occluded at its origin, so it won't bother you once you open the sac. And then at the bifurcation, the aneurysm ends. Again, the measurement is about 1.7, and we got a 1.9 at the infrarenal neck. So you can use about an 18 mm tube graft for this repair. And the IVS are normal. If you want to do the multiplanar imaging, you have to press this button, MTR, and you get a view like this. So you can see simultaneously the sagittal, the coronal, and the axial views. You have crossbars. If you want to exactly locate a point, you can, for example, if I want to examine the renal artery origin, I can place a crossbar into that renal artery and I can see the same thing on the coronal view. So you can also double click the coronal view and it will get expanded. If you want to remove the crossbar, you just have to press this button, and then you can scan the same images in the coronal view. You can measure the length of the neck if you would like. So also you would like to know which artery is lower between the right and the left renal artery. So in this particular case, it's the left renal artery. So if you're dissecting the neck and you want to go as proximal, you know which is the target you're looking for. So similarly, this is a fairly straightforward case. Another case which is not so straightforward. So if you again come to the axials, the first step is windowing. So again, scanning his thoracic aorta, you can see it's ectatic. And as you come down to the abdomen, you've got the celiac mesenteric that are very patent, and then the renals. So if you look at the renals, they are patent, but then the right renal is having a tight stenosis at its origin. So something to be careful about. And you can see that the aorta is unhealthy looking, irregular looking right from the base of the renals. So this is not a very good neck that we can that we would expect. And when you're coming down to the bifurcation, you can see that the aneurysm is not ending at the bifurcation, but rather the right common iliac is also aneurysmal. And the aneurysm is going up till the bifurcation of the right common iliac. You can see that the internal and external are both patent on both sides. The left iliac is ectatic, but it is not aneurysmal. And if you come back to the sac, the IMA is occluded. There is a couple of lumbars, so that's one of them, right in the middle of the sac. And then there is a pair that is there in the proximal end. So again, if you would like to see this in the recon view as well. And you can see that if you take the coronal view, This aneurysm is pretty close to the renal. This is the lower left renal, and that's the right renal there. So if you look at the sac, it is almost abutting both these sacs, both these renals on either side. So there is barely space to put an infrarenal clamp, and this would be a situation where you decide to do a suprarenal clamp and quickly proceed with the proximal anastomosis with the renal protection. And distally, you would end up having a bifurcated graft leading to the left iliac, common iliac, and the right common iliac, right iliac bifurcation. So in summary, just as we upscale ourselves in open surgery and endovascular techniques, we also need to master our techniques and our skills in planning patients, because that goes a long way in improving patient outcome and safety. Always study the images thoroughly, go through them in multiple views. It's a good practice also to make a sketch like this by yourself, so that before you go in for surgery, you can revise the plan immediately, and also you can share your plan with your teammates, your anesthetists, your assistants, your nursing staff, so that they also understand and follow what you intend to do and are in sync during the surgery. Thank you very much.
Great. So that one is sizing on a plain CT in cases of CKD, if at all. The second is, if a patient comes with a CECT abdomen, would you want a CT angio, or would you be satisfied with that? And the third question is regarding the curved NPR, not available in gradient but with 3-man or some place where you have to straighten it out for the correct measurement. Your views on these three things.
Right. So nice question, Safi. So number one, plain CT is absolutely good enough actually for doing measurements, because in open surgery you are not, like in endo, you are not so much concerned about accuracy of the sizing. You just need to be having a rough estimate so that you can put a graph that fairly matches the aorta. So plain CT does fairly a good job in a CKD patient, or even if a patient is coming with a rib rupture and you don't want to waste time doing a contrast. A plain CT does perfectly fine. So that's question number one. Number two was
patient comes with a CECT.
Yeah. That again, for an open surgery, CECT is, if a plain CT is okay, obviously CECT is also equally good enough. So, but in endovascular, of course, you cannot do the plain, you can't do CT exactly. So you want to know exact anatomical detail, proper angiogram is required.
Third is regarding the curved
NPR. For an open surgery, I don't believe we need to be that much precise. So I guess the simple reconstructions would do the job.
But endovascular you would need, because what you are seeing, the length, if it's little curved, then the sizing might be a little different.
The length is not important for us in open surgery. We can cut the
endovascular, the curved NPR,
the length exactly.
Tomorrow we have a discussion about CT.
So this was only covering the open aspects. We have another topic.
We fail to see the abstract.
Correct.
Main thing is lungs. So when we do see the once aorta is seen, we should see the aspect. Basically, we are worried about post-operative coronary issues, so we can see the significant locking changes or any bulbous there that can prognosticate the patient over the movement.
CT and you will order from the
thoracic
down to what level the order?
Generally it covers the groin. So thoracic aorta, obviously to know whether there is concomitant aneurysms.
Only precisely place focus for the.
So it should be entire chest, abdomen up till the groins. Till mid-thigh you can say.
Also we clinically
Entire scan of the body.
either we take aortogram or
Correct. So if you want to cover the popliteals, you need a second one.
One more simple question: what cuts would you ideally prefer for?
At least 1 mm. Nowadays cuts come as 3.3 and 0.5 mm. That is very good. But minimum 1 mm.
Nice presentation. Quick thing on contrast enhanced MR. You mentioned that contrast enhanced MR can be used in renal insufficiency.
Yeah.
My understanding is gadolinium, even though in patients with renal insufficiency, you cannot use when the GFR is less than 30. Can you clarify?
That is true. I mean, there is a theoretical thing about nephrogenic systemic fibrosis, but of late, in fact, in our radiology department, we have been left and right using MRI for even very CKD5 stage patients, and this is almost extreme rarity, and never had the bad luck to see it.
Using gadolinium.
Using gadolinium. The new gadolinium, I think it's called daughter, a new isotope. choose to go for a CT without contrast because no sir, we can like Dr. Satish suggested a CT without contrast can be tried first. That we don't have to worry about contrast. NCC, non-contrast.
Good infrared next is there. It's will give all the details.
The problem with MR is basically that you don't really get subliminary cuts.
Correct.
You get much thicker cuts with MR. So that is where probably the NCCT is any time better because you can take subliminary cuts and get a good study.
Rupture, impending rupture, impending rupture. Don't do a contrast CT so that it ruptures cytoplasm.
No, I think there are personal experience. I have seen patients rupture with post contrast, so I think.
Okay, so that's first thing. Second thing is in a patient with CKD with you inject contrast. Do you actually send back for dialysis or no?
Depending on what the CKD status is. If they are creatinine of maybe less than 2, I think you can just prehydrate, take care, and do this one. But if it's like a EGFR of less than 30, and you really have to do a contrast angio, I think dialysis definitely. I think it's better to get it after the CT because the contrast washout happens and the overload. The pulmonary edema is what people are worried about when you're doing contrast angio for CKD on dialysis patients.
Yeah, in case like the further consultation we can have like once the dialysis was done 1 day prior, we can take a chance. If it was done 3 days earlier, then these patients are borderline, then you should try to get the exit.
Yeah. The main after this study.
Excellent talk there, Siddharth. So, a couple of points. One is about the contrast everybody is talking about. I think we need to understand that every time you don't need to give 100 ml of contrast. Now you can, if you speak with the radiologist, you can do the contrast even with 40 to 50 ml. So there are newer protocols that can be used. And again with MRI, I think I'll be a little bit worried with gadolinium contrast if you are really using gadolinium in pre-dialysis patients. Okay, you just need one patient. Okay, the entire guidelines is to avoid that one patient. Don't say that I have used in 50 patients, nothing like that. If the instance is 1 or 2%, you just need one case after case, and when it happens, it is really significant for them. So my recommendation would be to use the time of right. You can still get good contrast if you don't use contrast at all in any of the MRI peripheral. So you can get very good results along with the CT, plain CT. You can have a good, and especially if you are thinking about open surgery, you really don't need a lot of details. So I think you can use that one.
But I believe the time of flight is not very good for aortic imaging as well as in peripheral.
So that's what the difference is whether you are planning for open surgery or endovascular. If you are planning for open surgery, all you are looking at is grossly that there is nothing else. It's not the aorta that you are concentrating on, it's about the other, what you have explained, whether there is vein behind, anything abnormal, whether there are any malignancies or other things that you would like to avoid. Okay. So one more point that I would like to add is, you have explained very well about everything you look outside the aorta, but especially when you are planning inside the open aortic surgery, think about the inside as well, because if there is a lot of muck in there, you may have to clamp the distal areas early before you clamp the process. Thank you.
I think about gadolinium, radiologists have not slowly started giving up that theory of having this NFS because they're actually using more often now than we asking them to use. Okay, I think residents should ask questions. It's more of an interaction. And faculty can also ask questions the residents might be asking, so that when you were residents, you would have felt some doubt, like Ajay was maybe simple things like giving dance before CT, after CT, all this comes to mind when we start out.
Recently the development of isoosmolar contrast like with the faculty in the borderline CKD patients, how feasible is it?
No, of course. If you have such a situation, you choose to go for the isoosmolar over the opening panel. It's always beneficial.
So we end the session. Thanks for
the tech of the whole thing gradient. What Robbie sir said, don't upgrade the software, but you need to have a minimum requirement of the system, the processor, the memory, and also in certain cases the acceleration card. the graphics card, which gives you a GPU, the graphics process unit. So all those things, do look into that. Otherwise, if you have a bad experience, then you tend to not look into that better, or you blame the software for it. So look into the system requirements also first. Is that?
So we'll end this session.
Thank you for watching. Log on to Effect News.